Thank you for joining our webinar today on the COVID-19 News You Need from CHEST 2020. My name is Stephanie Levine. I'm the immediate past president of CHEST and a professor of medicine at UT Health San Antonio and the South Texas VA Health System, and I'll be your moderator today. Today's webinar will center on a discussion on highlights, key takeaways, and important insights from the multiple COVID-19 presentations that were held at CHEST 2020. We have several questions that we didn't get to address after Dr. Fauci's keynote opening address, and we thought that we would start off with some of those. But with COVID-19 on the rise in most states in the US and worldwide, we welcome you to submit any questions you have in relation to COVID-19. We will also be addressing the questions that you submitted when you signed up for the webinar. So please welcome our expert panel. CHEST President, Dr. Steve Simpson, COVID-19 Task Force Chair, Dr. Ryan Maves, Live Learning Subcommittee Chair, Dr. Mangala Narasimhan, Vice Chair of the Chest Infections Network, Dr. Holly Keat, and a member of the CHEST COVID-19 Task Force, Dr. Neha Dangayat. Dr. Simpson is a professor at Kansas University Medical Center and is a member of the NIH COVID Treatment Guideline Panel. Dr. Maves is a critical care and infectious disease specialist at the Naval Medical Center in San Diego. He is also the current vice chair of the Disaster Response and Global Health Network. Dr. Narasimhan is a director of critical care services at Northwell Health System and a professor at North Shore University Hospital in New York. Dr. Keat is an associate professor of medicine at UT Health San Antonio and is the medical director of the Adult Cystic Fibrosis Program and is a transplant pulmonologist. Dr. Dangayak is an assistant professor in the departments of neurosurgery and neurology, the director of the Neurocritical Care Fellowship, and the co-director of the Neurosciences ICU at Mount Sinai Health System in New York. So with that, I think we'll move on to our first question. I'd like to address that to Steve. Steve, can you comment on why we are seeing some of the disparities in who is affected by COVID-19?
Yeah, I think that probably most everyone understands by now that there is a difference in outcomes and a difference in who's been hit by this disease, with large numbers of African American and Hispanic individuals being affected, and so the question is, why is that happening, and is it actually a racial issue, or is it more of an access to healthcare issue? And I think, by and large, the thought leaders in this area would say that really we have health disparities because of access to health services across the board. And our African American, in truth, our African American population, our Native American population, our Hispanic population, and numerous other facets, smaller minorities, so to speak, have had access to healthcare issues all along, which has affected basic underlying health. So we also noticed that you are more prone to this disease and more prone to doing poorly with this disease if you have chronic heart issues, chronic lung issues, diabetes, hypertension, and all sorts of things that arise from not being able to have adequate health care at the right time. And so there's a definite overlap between our minority individuals who are suffering from this illness and our minority individuals who haven't had health care and have some of those underlying diseases.
Thank you. Ryan, we have several questions regarding vaccine efficacy. How effective would a vaccine need to be considered adequate, and why? And are there relative advantages of some of the different vaccine platforms?
Yeah, and it's a great question. The FDA has set a threshold of 50% vaccine efficacy, which on one hand doesn't sound great, but on the other hand would be a really good year for influenza vaccination, right? A 50% efficacy. And I think along with that 50% efficacy, one would also hope to see an attenuated response to infection in people who still did manage to get infected despite vaccination. And that is really what we see with the public health impact of influenza vaccination, where even though on bad years you may have only 30, perhaps 40% efficacy, the reduction in severity in vaccinated individuals and the reduction in transmission due to those reductions has a benefit that goes beyond just the individual benefit of influenza vaccination. And I think thinking of, potentially many of us who are probably relatively low risk for both severe COVID and severe influenza, I don't get vaccinated for flu because of myself. I get vaccinated for flu because I'm a vector. And the objective of that is to block transmission to others. I presume the same is true of COVID. In terms of, obviously we would like higher efficacy. We would like greater amounts of protection, but that 50% floor is really based on some level on modeling from influenza. Now, these trials are all still in phase 3. Some are very close to completing enrollment, though. And hopefully we'll get better ideas of if one or more of these agents has achieved 50% efficacy. As far as the different platforms, and this is one of the interesting things, we've seen a lot of novel, or at least if not novel, kind of niche vaccine platforms now come to the forefront. Previously niche platforms come to the forefront. So one of the ideas here, I think when you read about COVID immunity, a lot of us focus a lot on antibody titers and the amount of antibodies. And there's been a great deal of attention both in the medical press and in the popular press about how levels of IgG, IgA decline potentially rapidly over time in people who've received COVID. But a lot of these methods really neglect the role of cell-mediated immunity, of T cells in our protection against respiratory viruses. And so a lot of these newer vaccine platforms is they're finding ways to induce cell-mediated immunity in addition to humoral antibody-based immunity. Traditionally, the only way we've really been able to induce cell-mediated immunity with a vaccine is having an attenuated live virus. So, in fact, the first vaccine, smallpox, is an example of that. And more contemporary vaccines, things like measles, things like yellow fever, mumps, rubella, these are all live virus vaccines that are in common use, varicella. The problem with all of those vaccines is that a live virus does introduce an element of risk to the immunocompromised, less immunologically robust members of our society, who are also the ones at the greatest risk of getting severe COVID. And so is there a way to get around that problem? And that's what a lot of these new platforms are. So for example, the AstraZeneca University of Oxford product, the chimpanzee adenovirus vector, is a replication incompetent virus. So it can infect, induce cell-mediated immunity, have antigen presentation to T cells and so forth, introduce that arm of the immune response, but it can't replicate in a host. So the hope, this still needs to be validated obviously in phase 3, is that this is something that could be given safely to higher risk individuals that you may not have been able to do if it was a straight up old fashioned live virus like the yellow fever vaccine. Another example of one of these platforms is the Moderna mRNA vaccine. And that's not the only mRNA vaccine trial in development, but it's the one that's furthest along. The idea with mRNA vaccines is that you introduce a segment of viral mRNA that encodes, in this case, for the coronavirus S protein, the spike protein that binds to the ACE receptor and then leads to penetration into human cells. So instead of inoculating you with with the antigen or with a virus that manifests that epitope, you inject mRNA taken up into your own skeletal cells, into your own skeletal muscle cells, into your own myocytes, which then will start to pump out S protein with antigen presentation along the same side. So there's no live organism in this, but you're inducing both a humoral and a cell-mediated response. So it's an interesting way around that problem. Now, haven't been any licensed mRNA vaccines, but there have been a number that have been fairly far in development. I would say the Navy was involved in a dengue mRNA vaccine candidates some time ago. Their mRNA vaccine candidates for Zika came pretty far along before Zika kind of went away, or at least from popular consciousness. So yeah, so there are a lot of, and there are a number of other novel platforms. And for those of you who were able to attend CHEST this year, Dr. Julie Ake, Colonel Julie Ake, who's the director of the military's HIV research program, gives a very nice overview of these vaccine technologies. And if you're interested in it, you should watch Dr. Ake's talk because it's great. Thank you.
Thanks, Ryan. Just a quick follow-up that came up in the chat. How long would you say the vaccine should be in trial before it's safe for the public?
Boy.
Hard question, I know.
That is a tricky one. I think that it would be nice to at least get a few months worth of data. I need to admit a small, not conflict. I am a site investigator for the AstraZeneca vaccine. And so I am not receiving any compensation for that, but I am involved in that trial. I'll probably be about number 300 or so on the paper. But but I think a lot of these studies are going to be doing interim analyses about 3 months in. That is not long enough, I think, to really establish, how often do people need boosters? Is it going to be an every year thing like influenza, which I think would be actually a really good outcome.
Oh, that was a question also, so good.
Yeah. Yeah. But I think right now we don't know, right? This is the fastest time we've rolled out multiple vaccine products in such a short period of time. I mean, I think the previous record was 4 years for mumps in the 1950s. And that was breath fast. So the fact that these products are coming to phase 3 trials so very quickly, the research isn't going to end. These phase 3 trials, even though one or more may achieve emergency use authorization or even FDA approval after only a few months of study, there is a very good possibility. Not very good possibility, I should rephrase that. These trials are 2-year trials at least, right? So these patients, these volunteers who've given their time to be enrolled in these studies will be on trial for 24 months at least to get a better handle on the kinetics of their immunity.
Thank you.
Thank you.
Holly, there were a lot of thrombosis-related sessions at CHEST, and there are several questions regarding how you manage anticoagulation, knowing that this virus predisposes the patient to thrombosis. Can you comment on that?
Yeah, there was some great sessions at CHEST, you're right. So I'll put a plug to take a listen to those, but I'll try to summarize in just a couple of minutes what they spent, a few hours talking about. It's impressive that, just since COVID has been on the scene in the last 10 months, there's more than 1,000 papers published about thrombosis and COVID and more than 200 review articles so far just over the last few months. So there's a lot of information out there. The moral of the story is that it does seem like the risk of thrombosis is higher in COVID than in some other viral infections, as much as about 30% in ICU patients or about 10 to 15% in floor patients. Will have some sort of venous thrombosis. As well, there seems to be an increased risk of arterial thromboses, which can have a variety of manifestations from limb arteries to coronary arteries to cerebral arteries, and even the great vessels have been reported to have thrombotic complications. And so it's an active question to what to do about all of these thrombosis and how to look for them. And so a couple of papers have looked at, should we be screening everybody? Should we just be screening patients who are symptomatic? And it seems like the consensus is really falling down on, we should be doing our usual standard critical care management. We should be looking for thromboses in patients who have evidence of a clinical manifestation and not necessarily screening everybody. Every time we send someone into the room of someone who's actively infected, that increases the risk of possible viral transmission to the staff members. And so we should, early on, I think some people were just screening every single patient that came in, but maybe that's not the right approach. And that's kind of being looked at now. And then in terms of why does this happen? Well, there seem to be a variety of different potential pathophysiologic mechanisms, from hyperviscosity. They seem to have these platelet-rich thrombi. There's been even some suggestion of lupus anticoagulant and impaired fibrinolysis. And then there's some vasculitis-like features, as well as there was a study just published earlier this month that showed an ABO linkage in association with disease severity. And it seems like patients who have or blood group A seem to have a higher risk. So there's a lot that we don't know and that we're going to continue to learn about this. But for right now, the ACCP has actually put out guidelines in terms of how should we be looking for this and then how should we be managing it. And so the moral of the story is have a high level of suspicion. If you see something that looks like it could be consistent with a thrombosis, do the test and find out if it's there. And then to the question of D-dimer, because that's come up a lot, and there really, again, is not enough evidence to say that we should be using D-dimer to guide our clinical practice, but it's something that we can look at because there is very clearly an association with higher D-dimer and higher mortality. And so something to factor into your clinical decision-making. Now, coming to should we be prophylaxing and how should we be dosing anticoagulation for prophylaxis? In general, most of the patients that we take care of in the ICU and on the floor who have COVID will meet criteria for standard thromboprophylaxis. And so we should be using agents that we would normally use in the doses that we normally would based on their other comorbidities. So if they have renal dysfunction, Lovenox is not going to be an option as much as heparin. And then in terms of the dosing regimen, again, really we should just be doing what we know works and what has been shown to work in the past. So standard dosing regimens. And then for people who do have evidence of a DVT or a PE, we should be treating it again based on their other comorbidities and the medications that they tolerate and continuing it for 3 months after, just as our usual practice.
Thank you. Mangala, you were on the front lines at the very beginning, and now again, you're seeing a surge. Can you comment on the mortality trends that you have observed?
Yeah, I think that's a good point, and there's been a lot of discussion about this in the press recently. So the mortality when we started seeing patients was extremely high. I think of intubated patients, it was around 65 or 68% mortality in New York during the first surge. And the papers that have come out recently, both from NYU and from England, have shown a decrease in that mortality, and very nicely have shown a decrease as time goes by 10% a month or so. Of mortality in ICU patients. So why is that is the question, and what has changed? I think that we have gotten used to taking care of critically ill patients with COVID, and that's a big part of it. I think our health systems are not overwhelmed. I mean, when the New York surge happened, we had patients being taken care of in all kinds of settings and environments and by people who are not critical care doctors, taking care of 20 and 25 critically ill ARDS patients. So the health system being overwhelmed, I think, is a huge play in this. And now we have one ICU with COVID patients where our critical care doctors are taking care of them. So that makes a big difference. Our ERs are not overwhelmed. We're able to triage patients better. We're using a lot more non-invasive ventilation prior to having to intubate people or not having to intubate people. So, and I think in terms of treatment, we've at least got some consistency in what we're doing. When the March and April pandemic started, we were using tocilizumab and we were using an IL-1 and we were using, some people were using ivermectin and some people were using, there were all these anecdotal reports in the internet of how much PEEP to use and what to do. And people were very confused, and time has sort of settled things out. And there's been some very good studies that have come out that have helped us decide what is best treatment. While we don't have perfect treatments, I think we have at least consistency in what we're doing, and that has changed things a lot too. And we're not jumping at everything that comes, our way through the internet. So I think all of these factors together play a part in what's happening. I also think there's a little bit of a change in the patient population, that we were seeing a lot of elderly patients when the first round of events happened in March and April. People now are wearing masks. The elderly are staying home and practicing social distancing, and have really changed their behavior patterns significantly. So the people we're seeing now are a different patient population. And there's a theory that wearing masks and having reduced viral load changes the severity of disease. So that may play a part in it. I don't think that's really been totally confirmed yet, but the less viral load you get when you get sick, that seems to play an impact on the severity of what you get. And finally, there are some reports, and none of this has really been verified, that the virus is a little bit different and it has mutated. I haven't really seen that. I think the patients who do get to the ICU are still as sick as they were back in March and April. There's just much less of them, and we've been able to keep them out of the ICU and on other treatment modalities in other places in the hospital. So I think all of these things together have played a big impact on mortality, and I hope we continue to improve it. It's still much higher than the flu, and it's still something to be worried about. And it still has a huge mortality as compared to other diseases, but I think it's a little bit different in the way that we're approaching them and the number of patients that we have.
Thank you. And Neha, one of your interests is in long COVID. There were also several sessions on that at CHEST 2020. Could you expand a little bit upon that?
Absolutely. And of course, CHEST had a fantastic session moderated by Wes Ely and Oluko Hope and Rana Avdesh. So I'd ask everybody to take a listen to that. And in terms of what long COVID really is, how long is long, I think for us to be able to understand and get wrap our heads around the duration of symptoms, it might be worthwhile classifying patients into those who are not sick enough to be hospitalized. So those patients who are self-monitoring their symptoms. Then there's a category of patients who will get hospitalized, but they're not sick enough to come to our ICUs. Then there are those 5 to 10% patients who are going to get critically ill who will be in our ICUs. And as we're longitudinally monitoring these different categories of patients, I think we're seeing two different flavors. One is persistent symptoms, which are very similar in some ways to some prior post-viral syndromes that we have seen. For example, a post-EBV syndrome or a myalgia, encephalomyelitis-like syndrome that has been described after different viral infections like Q fever, etc. But how is long COVID really different? So in that patient population that did not have very severe symptoms from COVID-19 and are self-monitoring their symptoms at home, a UK-based study reports that almost 60% of these patients are reporting symptoms all the way out to 8 weeks or so from their first symptom. There's also another longitudinal study, again, out of the UK that's really going to monitor these patients, whether they were PUIs, whether they got a confirmatory test or not. And I think that's going to help shed light on some of those patients who self-monitored their symptoms. Out of Mount Sinai, we have our Precision Recovery Program that's also enrolled about 1,000 patients. And what they're describing is very similar to what we've seen from other reports in literature, where this brain fog, fatigue, difficulty in thinking, concentrating, GI symptoms, shortness of breath, just muscle aches, generalized weakness. So these are some symptoms that are ongoing. And then for patients who have been hospitalized, again, out of the UK, there's a longitudinal study, the FOSS COVID study, that will shed some more light on this. Then for the ICU patients, we've known even in the pre-COVID-19 era that post-intensive care syndrome is a public health problem. We know that anywhere between 40 to 70% of patients are going to suffer from a problem in one of these different domains, the physical domain or the cognitive domain, behavioral domain. Is the burden of post-intensive care syndrome going to be much bigger in our COVID-19 patients? So during Dr. Wes Ely's session, it was pointed out that perhaps this F-COVID, the lack of family presence or this feeling of isolation, problems with oxygenation, clotting, all the medications that we're using, that's definitely going to be a bigger burden. This D-COVID study or the delirium COVID study that again comes out from the same group, again, an international study that enrolled more than 2,000 patients. Again, what they're seeing, what is different about the delirium that's happening with COVID-19, which is a known risk factor for post-intensive care syndrome, more than 80% of these patients received benzos for a prolonged period of time, so for more than 7 days or so. So we know that a lot of the things that we had made progress in preventing post-intensive care syndrome using the A2F bundle, the adaptations to that bundle have been very difficult for several hospitals and health systems, particularly like Mangla said earlier in the pandemic, we didn't know exactly what we were dealing with. And as studies out of the UK are pointing out, that overall mortality is getting better. We do anticipate that outcomes for patients will also be better later in the pandemic as compared to earlier in the pandemic. But this global collaboration for monitoring these patients longitudinally, leveraging the existing networks of post-ICU clinics. And there are several hospitals and health systems in the UK, in Italy, in India, in the United States that now have special COVID-19 centers or COVID-19 clinics, really trying to coordinate the care for patients who have pre-existing disease and then they got COVID-19. And then how do we track all of these different symptoms and what does it really mean? From a pathophysiological standpoint, it's hard to know whether this is because of reactivation of the virus. Is it because there's a dysregulated immune response? Is it because of a compounded effect of the disease itself and the treatments that we have administered? So all of that is going to be difficult to tease out. But the most important thing that I heard during several sessions in CHEST is this collaborative approach that we've got to pool our data and follow these patients longitudinally. Lots of press on how patients are feeling like their symptoms are not being taken seriously or people are being told this is all in your head. I think we have to be very mindful of doing that and addressing the needs of these patients appropriately till we completely understand what we're dealing with.
Thank you. Steve, can you comment on the role of public health officials and public officials to assist healthcare professionals during the pandemic?
Yeah, I will try and do that. Not everyone knows probably that is viewing that I work half of my time in the Department of Health and Human Services myself. So I'm not going to give you any government spiel, but I want you to understand that our public health officials, they function in a couple of different ways, whether it's at the local level, the county level, the state level, or the federal level. You have afferent limbs and you have efferent limbs, and we've seen a little bit of a bit of topsy-turvy here with the afferent and the efferent during this COVID outbreak. For example, one might not normally turn to the director of the National Institute of Allergy and Infectious Disease to be your efferent limb, to be the person who's putting out the public health information, but this is the way that it's worked out. Normally, we would expect the Centers for Disease Control to be both afferent, gathering data from what's going on in the communities, and efferent, synthesizing that data. And what happens, though, is there's a thing called policy that gets in the way here a little bit. And policy takes the afferent data, makes it into this is how the government's going to behave, and then spreads that back down through the government. And that also happens locally, statewide, and federally. So this is all going on at once. What I want to say, though, is yes, there are some politics involved in how policy is set. No question, we can all see this. But my experience with the federal government, my experience working with our current state, the right word isn't Surgeon General, but he's the director of our state health agency, and our county health officials, all up and down the line, there are thousands and thousands of dedicated people who are here looking to form a scientific approach based on data that makes sense. And that is their job. And that's what they're all there for. And there are lots and lots and lots of them. And I play a teensy little role in the federal government, contributing some critical care expertise to an overall plan to help get better testing and get vaccines and get potentially therapeutic agents. But I think that's the key thing. Your public health officials are not there to lie to us. They are not there to set a political agenda. They're there to scientifically interpret the data that's coming and to give us scientifically based information that helps us make our clinical decisions and our personal decisions. And I think That's what I'll say.
Thanks. Ryan, early on, we were certainly worried about viral co-infection. And now that we're heading into the winter in our hemisphere, that question's coming up again. So should flu and COVID patients be isolated from each other in different units? Or is it okay to isolate them in separate rooms in the same isolation unit? That's a question that came up on our live Q&A. And then your prediction on given mask wearing, what we'll see in terms of influenza this season.
Yeah. In terms of isolation, I think that in general, patients, it would be very challenging to cohort influenza and COVID patients together. And in general, I know that in times of crisis, we've had perhaps 2 COVID patients together in an ICU and so forth. I think when you introduce influenza into the mix, there is at least some observational data that there is a synergistic potential for harm. And I would certainly try, assuming that we haven't moved into crisis standards of care or something like that, to do our best to make sure that flu and COVID stays apart from each other, not together. In terms of, and that's the former infection control chair speaking. When it comes to kind of the clinical implications of that, right now CDC and the NIH COVID guidelines are recommending that our use of oseltamivir for COVID influenza co-infected patients should essentially be the same as our normal oseltamivir indications, right? So patients at risk for severe influenza and so forth. I would say that probably when I identify someone with COVID and influenza at the same time, I suspect my personal threshold for starting oseltamivir may be a touch lower than it normally is. And I suspect that my threshold for admission is going to be a little bit lower than it normally is. But right now, until we have better data, knowing what is the actual impact of these co-infections on a larger scale, I think we have to stick with conventional guidelines for treatment and also conventional guidelines for hospital infection control. And I would try to minimize cohorting to the extent possible based on the research. Yeah, as far as what masking is going to do to influenza, this came up in our session at the live meeting. And one of the interesting observations was that the local surges in the Southern Hemisphere this past North American summer corresponded with South American and Southern Hemisphere winter and influenza season. And so countries that have fairly robust public health surveillance systems, Australia is one great example, Chile is another great example, saw very, very little influenza during their flu season. So, this gives us hope that if we in the United States wear masks aggressively, appropriately, take appropriate social distancing, it is possible that we could avoid a twindemic, I think is the phrase I've heard written down, of simultaneous influenza and COVID. It's worth remembering that the first reported death of COVID outside of China was a gentleman in the Philippines who had influenza and COVID co-infection, right? So clearly this is a combination we would like to avoid. But I think if we do our part, we as clinicians and as members of CHEST, if we, model appropriate behavior for our colleagues, for our patients, wear masks, use good eye protection ourselves in the hospital, cautious optimism, we'll say, cautious optimism. Thank you.
Thank you. Steve, you have a question.
Yeah, I'm sorry, to other panelists, I wanted to make a tiny comment and focus this at Ryan, because it was one of the questions I saw in the list that I found fascinating. And that question was about being on ships and submarines and passing things around, understanding you can't talk Navy, you can talk about cruise ships if you desire. But the part of the government I work in too, that's called the ASPR, the Assistant Secretary for Preparedness and Response, views what we're doing as health security. And that's because literally, if you wanted to attack the country, and you developed a biological weapon, not saying that anyone has, mind you, but I'm saying that if you wanted to do that, a good way would be to put out something that infects and destabilizes both the military and or the government, even all the way up to President of the United States. And so we view it as security, and I just found it interesting. My personal thought is I think that probably our sailors ought to be among the first in line to be vaccinated, understanding they're mostly young men and women and lower risk, but nevertheless, it's important. I'm just curious what you can tell us about that or say about that.
Oh, well, so standard caveats. The following opinions are the opinions of myself do not represent the official opinions of the Department of Navy, Department of Defense of the United States government.
Yes.
But I am a Navy captain. So I would say that I've actually been really pleased with how we've done as an organization. I'm speaking as a naval officer, but of course, the Department of Defense generally in our approach to COVID, because obviously the military is an organization that has to deal with the world as it is. We have to send ships out to sea. We have to have the Marine Corps ready to go be the Marine Corps. We can't take a break from it. So here in San Diego, we have the Marine Corps Recruit Depot, which is one of the Marine Corps' 2 boot camps. Basically, west of the Mississippi, recruits come to San Diego. East of the Mississippi, they go to Parris Island. And the Marine Corps leadership there, and I was lucky enough to play a small part in the development of these plans, puts new recruits into, they're tested upon arrival, then they're put into 2 weeks of what we call ROM, or restriction of movement, but basically quarantine. And then tested again at the conclusion of that period before entering into training. And then the squads, the training companies are kept as bubbles, basically, bubbles moving around. That's not to say there haven't been cases of COVID among trainees, but what's interesting is that respiratory infections among military recruits is kind of the great bugaboo that we contend with at my hospital, where, recruit pneumonia is like my residents, when they admit a recruit with pneumonia, the entire presentation is 19-year-old male recruit pneumonia, right? It is such a common presenting syndrome. Recruit pneumonia has gone because of these public health interventions that the Marines have implemented to reduce the risk of COVID, masking, cohorting, and isolation, to the point where, and again, this is kind of rumor at this point, but one wonders, should we do this forever? Should we continue these public health interventions forever if they lead to streamlining of training and improved health of military recruits? Ships use a similar system before deployment of restriction of movement for 2 weeks prior to a crew embarking. So there's this whole notion of a crew being in a clean bubble when they embark on the ship. And so far, it's been pretty successful. Obviously, the outbreak on the USS Theodore Roosevelt aircraft carrier, mail just arrived, aircraft carrier was well publicized, and there is actually a very nice CDC report on that in MMWR, written by CDC and Navy and some Army personnel as well, that describes the interventions. But one of the interesting things about that, again, is that sailors who were wearing masks got less COVID. It's very clear, very strong link. And so, yeah, as far as priority of vaccination, I'm in no real position to make any specific comments about that. Obviously, the military tends to be pretty early in the line for vaccines, but I certainly think that we should not do that at the expense, people of color, patients living in nursing homes, all of these other very high risk groups as well. There's a lot of people who need this quickly.
Good point. I would say sailors get my vote for being pretty far up there, though.
I appreciate that, sir. Thank you.
Holly, you take care of a lot of patients with underlying lung disease, transplant, CF. So some of those clearly are comorbid risk factors. Some of the data, for example, in CF seems a bit more mixed. Is that because they were the original socially distant population? Some comments on that.
Yeah, it's really interesting. So we know pretty clearly that COPD, tobacco use, smoking seem to be risk factors for developing more severe COVID. But some things that we thought initially might be risk factors haven't really borne out so much. Asthma being one seems to be a little bit mixed, as well as CF seems to be a little bit mixed. And the question is, are those populations just really good at staying 6 feet apart? Are they really good at masking? Well, yes, they are, because they've been doing that throughout their whole life, especially in the CF cohort. But there's also some question about whether the CFTR might have some protective effect, and whether the inhaled corticosteroids that people are on downregulates ACE, and whether that has some interaction. So there really is just so much that we don't know to answer that question. There was a very good session at CHEST, though, about telehealth and implementing that into the clinics, because it looks like, for the foreseeable future, COVID is going to be affecting our outpatient practice. And so how we are adapting to that in our clinics, and how we are reassuring patients and doing their best things to keep them safe, I think is something that's important for us all to be evaluating in our practices. And there are definitely some strategies that we can take to be more successful than others. But one thing I thought was very interesting from that session specifically was the number of people who have a smart device. In surveys, even amongst people of color, even across socioeconomic status, it's more than 78, 80, 85% of people have a smart device. And so we should really be offering those services to patients when it's convenient for them. And especially since CMS has lifted the restrictions on telehealth going through the end of the year, that's something that we should really be adapting, I think, in our practices.
Great, thanks. Mangala, can you talk a little bit about your approach now to the management of mechanical ventilation? And there was actually a very specific question on driving pressure even that came in the people who signed up for the webinar.
Yeah, absolutely. We, from the beginning, have been using ARDSNet best practices for our patients with COVID, and we are really still sticking to that very much. We are following driving pressures, following plateau pressures, using 4 to 6 cc's per kg ideal body weight, tidal volumes, and we have been sticking to those best practices, lowering FiO2 as much as we possibly can, increasing respiratory rate to increase minute ventilation, and we're following blood gases, obviously, and we're titrating the ventilator as we can. So the question that came up in the chat was, do you tolerate hypercapnia, permissive hypercapnia, in order to decrease driving pressures? And absolutely, yes, we do that. And we've been doing that for a long time. And we do that for these patients as well. And to what pH do you go to was the question. And I think our standard is, if we get below 7.2, we start to get a little bit unhappy with those numbers, and try to fix that as much as we can. We did a lot of VV ECMO for our patients during March and April, and we had patients who got to the point where we had done everything best practice wise, and we were hurting them now with the ventilator, and they were otherwise good candidates for VV ECMO. We were putting those patients on, and our mortality rates from our VV ECMO program were pretty good. Just very long ECMO runs, very long ICU stays, a lot of sedation. So it took a long time to get them off, and that can be troublesome when you have the number of patients that we were seeing at that time. So it was a lot. It was very resource intensive, one-to-one nursing, and we had perfusion involved. So it's not something that is doable, I think, everywhere, but there are centers of excellence in most cities where you can be sending your patients. But ARDSNet best practices, absolutely. And in terms, there's a lot of discussion about low or high PEEP, and I think that's really patient dependent. If we were hypoxemic on good settings, we would go up on the PEEP and make sure that we weren't hurting that RV, and continuing to monitor the RV to make sure that there was not negative effects on that. But I think the one unique thing with COVID that we hadn't seen in a long time is the number of pneumomediastinums and pneumothoraces I don't really have a good explanation for why that was, but it wasn't even necessarily in patients who were intubated. We were seeing it in patients who were on oxygen, patients who were just had worker breathing. So that was something sort of unique and different about COVID that was different than other ARDS. But otherwise, we were doing RSNAP best practices the whole time. Yes.
Steve, anything to add there?
No, I just find it fascinating. This is the second time, Mangala, that I've heard you say that about the pneumomediastinum, and I've heard other people say, and we just haven't seen that ourselves so much.
Interesting.
I think it's fascinating how this thing does seem to somehow change as it moves across the country. And of course, what we have where I live is it comes from the left coast and the right coast, and I'm not sure whether what we have is the same as either side or both.
It's interesting.
It's fascinating.
There is a question, Stephanie, just about early trach versus extubation, the VV ECMOs, and I can address that quickly.
Sure.
These patients, most of them did get trachs. They were not early at all. They were late trachs. They were somewhere between 3 and 4 or 5 weeks. And if we could extubate, we obviously did, but they usually took a long time to get better. So they ended up, the VV ECMO patients being trachs, but later on.
Did you do anything differently with your chest tube insertion?
No, we did not. We usually use very small pneumothorax size tubes so, not big French tubes, and that took care of the problem. But someone in the chat is saying that these patients take high tidal volumes and spontaneous breathing, and that may be the cause of it. And that's what we thought as well, that it was just the work of breathing and big tidal volumes and swings of pleural pressures that were causing it.
And regular PPE for your chest tube insertions, nothing different?
Nothing different, yes. And someone else in the chat is saying that they've seen a lot of pneumomediastinums as well. So interesting. I'll hand it back.
Neha, I definitely don't want to end without, I know we have a little more time, but you have an interest, of course, in wellness. We all do, but I know that that's something you've been quite interested in. Could you expand a little bit on some of the techniques that you have used in your healthcare system?
Absolutely. I think in terms of wellness, we've been fortunate that even before the pandemic, across the country, several major medical societies in different subspecialties really came together to focus on this issue of burnout in the healthcare field, and specifically looking at this on the conversations on social media using that hashtag ICU burnout, and what were the themes that were emerging there and how can we prevent that. So most hospitals in the United States already had some really good pre-existing resources, or at least some thought and conversation around it, to the extent that I know GME offices have a mandate that you have to have every department appoint a wellness representative. We, for our health system, have a chief wellness officer, and in terms of coordinating the responses across the different departments, I think making sure that technology is being used appropriately, that all those principles of communication during crisis, what does our frontline team need at this moment in time, making sure that communication is really transparent and accurate, and the acknowledgement of, okay, we don't know this, but we'll figure it out. I think that was a key component of wellness, that reassurance that yes, we're going to come out of this, and this is our plan for the immediate future. We're keeping our hands on the pulse of this rapidly evolving pandemic. So I think a lot of hospitals and health systems across the United States and in different parts of the world did a really good job of that. For us specifically, I thought our health system did a phenomenal job of quickly putting together this task force, and then later evolved into this Office of Resilience and Wellness Promotion. And then again, leveraging technology for providing compassionate care to all the frontline providers. There was this wellness hub that was created, an app that all of us could sign up for, and there are different resources that you could use by way of that app. Another really cool initiative was these recharge rooms, essentially a place where you could take that moment to unpack and process everything that's happened, even if you didn't have the time to do it. So just taking those few moments and making sure that everybody was still wearing masks while you went into the room, but you could at least take a moment there. We did some wellness sessions using Zoom, including our spiritual care team, just organizing some meetings where people could just talk through what they were going through, or verbalize their fears, and come up with some strategies for how to channel those fears appropriately. And perhaps, this may be a little underrated, but free food, I think that really fed everybody's souls. And getting all these food donations from the community, and several of our team members coordinated these food donations. I thought that was incredible. But all in all, just like everything else, because we had some good practices in place before the pandemic, then you can just magnify those good practices and then adapt and fine tune them for the needs of your team at that moment in time. So, and I think Chest did a phenomenal job. We had several webinars on wellness. The Chest meeting had a bunch of content on wellness. So I think there was no doubt that everybody realizes this is an important component of doing everything that we do.
Thank you. Mangal and Steve, a couple questions regarding our change in practice and when to intubate, the use of non-invasive ventilation, high flow nasal cannula.
You first, Mangal. Go ahead.
No, I was going to say you first.
Okay, well, then what I will say is that we have morphed, and I think other people have morphed during the course of this. There was a time early on, as Mangala was alluding to, when there were theories about whether this is something different from ARDS or something new or strange. And I think we have learned that actually it isn't. What we get to see is the evolution of ARDS in a way that we haven't always gotten to witness the evolution of ARDS. We have changed our approach, and I think this is fairly in line with pretty much everyone, that instead of the first person that I intubated with COVID, we went directly from a 6-liter nasal cannula to being intubated. And we now understand that isn't necessary. There are plenty of stages in between, and the stages do consist of both high flow nasal cannula, heated high flow nasal cannula device, BiPAP type devices, and all the way to intubation. And we do know that some people stop at that level and don't need to go farther. And we were concerned also early on. I think one of the reasons that we intubated people early is we were concerned about spreading the virus both to ourselves and to others in the room during the intubation. And we now understand that with good PPE, good PPE, for one thing, that is less of a problem, and that perhaps there is less aerosol spread from heated high flow nasal cannula than what we thought might happen earlier on in the illness. So we are worried less about transmission of the virus now. So basically, our philosophy at this point, and I think this matches up, Mangala, you'll say whether it does or not, but I think our philosophy is as long as you can oxygenate a person well, and they are not exhibiting signs of failure of their own ability to pump the air in and out, then you can take your time working your way through these steps. And it is when people begin to show evidence that their ventilatory efforts are about to fail, that they need intubation. And that's fairly similar, I think, to just almost anyone.
I totally agree. The one thing I would add is there is some data that we're seeing preliminarily that patients who get intubated in their first RRT, when they're starting to get into trouble, do better than the ones who go to their third or fourth RRT. And as they get sicker and we wait longer,
Yeah.
that those patients don't do as well. So there's some sweet spot in between where we don't intubate too early and we don't wait till they're in extremis and working very hard with high pleural swings to intubate. And I think that's going to be different for every patient. So yes, I totally agree with everything else that you said.
Thank you. Ryan, a few questions regarding what we're starting to see now, that someone who stays positive on their PCR for weeks and weeks and weeks, but with resolution of symptoms, what do we do?
Well, I mean, the short answer is stop checking.
Yes.
Yeah.
And our infection control would say that here.
Yeah. So the CDC's put out good guidelines, and this is based on a lot of look at kind of the kinetics of viral cultures over time, which is not a routinely performed clinical test. The problem with PCR is that it doesn't distinguish between viable and replication incompetent virus. So we're basically, these persistently positive PCRs, as far as we can tell, in the majority of patients, essentially seem to be detecting like chunks of virus cadaver. And so the current guidelines are now for kind of the typical patient with COVID, assuming that they have clinically improved, are free of fever, are on the mend. This is separating out, of course, the issues of long COVID. This is not requiring someone to be totally back to baseline, but clearly improving in afebrile. 10 days out from symptom onset, we can generally relax infection control precautions in those patients. In the critically ill and the mechanically ventilated and the immunocompetent, we would extend that out to 20 days. And I think that is, broadly speaking, the correct thing to do. How we apply that to a given hospitalized patient, the person who's been on the vent for 23 days, and how you institutionally manage the liberation from those precautions, I think the data would support a 20-day time in the penalty box, and then hopefully being able to lift some of those, fully appreciating that every institution is going to have its own individual level of comfort. And not just the organization, but the staff, right? Making sure that nurses, physician colleagues, and others are comfortable with that decision. That's the thing I've seen at other hospitals, where socialization to make people comfortable with that idea. But I think for the great majority of patients, 10 days or 20 days, depending on severity of illness and underlying immune status. And I do not recommend repeat PCR-based testing for someone who already has a diagnosis of COVID. Right.
Okay, thank you. There are a couple questions regarding fibrosis after severe COVID infection. What is the incidence? I think it's probably too early to determine that. I think we know, based on some of the lung transplants that have been done and what the explants look like, that there certainly is a component of irreversible end-stage lung disease. But does anyone else want to add more to that?
I will just add that I think over the 30 years of my career, it's become clear that much of the fibrosis, and in fact much of the severe ARDS that appeared for various different reasons, whether it was caused by sepsis, trauma, you name it, that much of that was us. And much of it was volutrauma / barotrauma / shear forces, and the various things that we did with machines wound people up with it. And I think that particular component of it is going to remain true of COVID. And this isn't to say anyone's doing anything wrong, but sometimes the way ventilation goes is just not the right way. And so is this COVID induced? Is this antibodies to COVID, cellular immunity to COVID that induces this, or is this cellular and humoral immunity to the mechanical forces that must be applied that wind you up with fibrosis? And I don't think we know the answer to that just yet.
Any other comments on that?
No, I'm good.
Well, I think we're drawing to the end of our hour. I don't know if there were any. Oh, Ryan answered something. I didn't know if there were any other kind of parting words from anybody. I really appreciate everyone taking the time and bringing their expertise to the group and trying to summarize what they learned and heard at CHEST 2020. And thanks to CHEST for allowing us to put this on.
My parting word is I feel smarter after listening to these guys than I was an hour ago. So thank you.
Same here.
think
Thank you all so much.
Thank you, guys.
Thank you.
Bye.
The outlook's going to be really positive. So we just got to stay on top of everything that's happening. These last 2 months are sort of like the last leg of a marathon. Like Ryan said, there are a whole bunch of good vaccines that are on the horizon. We know a lot of the social distancing, the masking, the public health efforts work. So we shouldn't get tired of that at this point in time. We're so close to really beating the virus.
Great.
Thank you.
Thank you all.
Thank you all for the
Bye.
opportunity.
Bye.
Yes.
Thank you.